I'm Peter Rutherford. I'm the Chief Executive Officer for the Rural Doctors Association of Australia, and really proud tonight to be bringing to you our first of our grand rounds, our virtual grand rounds, which was an idea from our Doctors in Training Special Interest Group as part of our Destination Rural campaign, so we can demonstrate the huge variety of medical care and interesting cases that are rural doctors encounter every day of their working life. And tonight we've got the chair of our Doctors in Training Special Interest Group, Dr Marian Dover, presenting. So before I hand over to Marian, though, I would like to acknowledge the traditional owners of the land we meet on across this great nation, and pay my respects to elders past, present and emerging, and also acknowledge any Aboriginal or Torres Strait Islander people that may be joining us online tonight. And thank you for your insights, your care, and certainly the value that you provide to us in providing services to doctors all over the country. So thank you. But without further ado, I will hand over to Dr. Marian Dover, and we will commence our first presentation. There will be plenty of time for questions, but if you don't feel that you want to put your hand up at the end, happy to monitor the chat, and we can ask some questions from the chat as well. So thank you.
Thank you, Peter. And welcome everyone. Give me a minute while I just share my screen. I know once I share my screen, I might not be able to see the questions, so I might get Ben or Dan or Jean to just keep an eye on the chat for me. But yes, welcome to all of the new faces that we've got online, and welcome to our first grand rounds. I'd also like to pay my respects to our Aboriginal and Torres Strait Islander traditional owners of the land, and their elders past, present and emerging. So a little bit of background about our group. So we are almost like a little subgroup of the Rural Doctors Association of Australia, which is an organisation that advocates for rural doctors. We are all sort of junior doctors across the country in different states, and I've got to say, as someone who was born and raised in the city, I sort of started off my rural journey as a bit of a rebel, and that was sort of the play on words that I chose for the title for the case tonight. Fever without a cause, but I was a rebel without a cause when I started my rural journey. I decided I was going to move out of home at 18 and delve into an adventure that was going to be rural medicine. And it turned out brilliantly. I was met with lots of acceptance and a sense of community that I hadn't really encountered before. As a group, the Doctors in Training groups for the Rural Doctors Association, we support each other, quite well, and we share experiences of things that we sort of do day to day in the different states across Australia, and we're a very strong support network for each other. It's been really nice to get to know the people that I have through the Rural Doctors Association, so I welcome you guys to join us. We'll start our case tonight. So this was a case of a young boy who presented to a rural emergency. I wasn't on when he first came, but he was from a migrant family who just moved to the area a few months earlier. We didn't really have a lot of medical history about him, but he presented with a 2-day history of high fevers that seemed to be sort of quite, had a pattern to them where his fevers were sort of happening more so in the afternoon and in the evening. And Mum said that the temperatures were consistently above 38.5, above 40 at one point. And at the same time when he was spiking these fevers, he was also getting this quite severe generalized abdominal pain. He felt quite nauseous and he had a bit of a headache when it happened. he had no change to, I guess, his bowel habits. He seemed to have sort of these episodes where he wouldn't open his bowels for a couple of days, when that coincided with the fever. But in between these episodes, he was completely well. And yeah, I guess the interesting thing was there was no one else at home who had the fevers. There was, mum and dad were both well. He had a brother who was also well. And the fever didn't seem to respond to Panadol and Nurofen. And that was both for the fever and the pain that he was getting. Right, so the background to this story was that this was a otherwise quite well child. His immunizations were all up to date. He was born at term, vaginal birth, nothing exciting there. Mum says that these episodes seemed to happen when he was a bit stressed, and he had some exams that had happened in the months preceding to this. But Mum was insistent this always got better with antibiotics. And it seemed like he had quite a few different antibiotics with each presentation. His 17-year-old brother was well. And like many of the migrant families that lived in this town, his dad worked at the abattoir in town. He wasn't on any regular medications, not allergic to anything. And really his background really didn't give us too many clues. And it's doing the same thing again, sorry. There we go. On examination, and this is from the notes from one of my colleagues who saw him the first time, he seemed to look like he was quite uncomfortable with the pain that he was in. His temperature was 39 degrees. He wasn't tachycardic, but he was quite hypotensive at 78 on 50. His saturations were fine. It didn't seem like there was a respiratory source to this at all. Chest was nice and clear. Heart sounded normal. But his abdomen was quite tense. There was some rebound tenderness, and there was some guarding. The doctor that was on felt that his spleen was mildly enlarged. It was palpable, but his liver was normal. Murphy's sign was negative. He did have bowel sounds. The doctor sort of described it to me as you had to be listening for a good minute to hear the bowel sounds, but they were there. And this boy had pars flatus, but just hadn't opened his bowels for a couple of days. His urine was clear. So I kind of want to open this up to the group, and we'll say Dan or Jean or Ben, if you can keep an eye on the chat for me. Can you guys just throw out what investigations you'd like to do for a patient like this? What would you start with?
I start with, Marian, maybe the setting of where you are and what you have available as guidance as to what we might be able to get. Is that okay?
Yeah, that's a great point. So this was a town MMM5 location. We had ISTAT bloods. We didn't have pathology on site, but most of the bloods would be back by later that night or the next morning. We have X-ray available, but no other imaging. So there's a bedside ultrasound if you're really nifty, but otherwise it's X-ray, or we transfer him for CT or MRI.
Well, he's febrile, so I think some basic pathology, ISTAT, and taking bloods for cultures and formals to be sent away, I think would be a reasonable first step to look at his inflammatory markers.
Brilliant. Thank you, Ben. I won't be mean. I'll move on to the next slide. So on the ISTAT, which is pretty much the only one that we got immediately, his lactate was 0.9, not too exciting. Once we got some of these bloods back, his hemoglobin was 115. His white cell count was elevated, but not markedly, with neutrophils of 5.3. CRP and ESR both elevated, but D-dimer was negative, and creatinine was 89. His renal function was normal. So all of the cultures were pending. And because this was a boy who lived in the same household as someone who worked in the abattoir, we specifically asked for brucellosis, lepto, and Q fever, but all pending. We're not going to get those results immediately. And this was his X-ray. looking pretty normal. There was no air fluid levels, nothing to suggest that there was an obstruction, nothing really to give us more clues from there. So the doctor that was on that day admitted the patient and got some advice from the ID physician that we should treat this as a abdominal source of sepsis, because he was hypotensive, not quite tachycardic, but he was hypotensive and febrile with an elevated CRP and ESR. They started him on, I believe it was IV Augmentin at that point. But within 36 hours, it probably didn't even take quite 36 hours, his symptoms almost completely resolved. So the doctor that was on, we switched the boy to doxycycline, because by then we didn't have the Q fever, brucellosis, and the leptospirosis results back. So changed him to doxycycline, and he was discharged home. 4 months later, this time I was on in ED, and basically a very, very similar presentation. He came in hypotensive with a very high fever. Panadol and Nurofen wasn't doing much. He had the abdominal pain. I guess the only thing that I sort of commented on was when I met him, this boy was about my height, and if anyone has seen me in person, I'm not very tall, and I thought that was interesting for a teenage boy to sort of not be as well grown as his mum was. His mum was actually substantially taller than he was, but apart from that, the examination was very similar to what my colleague had found a few months earlier. Has anyone got any ideas? Are you starting to get an inkling of what we should be looking into? Want to give it a go, Dan?
Well, I'm thinking some sort of chronic disease, given that if he's as tall as you are, then he's really stunted. No offense. Thinking something like either a chronic disease that's autoimmune, potentially, I'm thinking along the lines of like axial spondyloarthropathies, but probably shouldn't produce a fever. And then otherwise, I'm thinking around weird and wonderful viruses like HIV, hepatitis B and C. But again, maybe not febrile. So I'm still a bit unsure.
Yeah, brilliant. You thought of a lot more than I did, Dan. So I felt like I was going to go off on a little bit of a limb, and I decided not to give him antibiotics. And I sent off a few more bloods for some other investigations. This was a little opportunity for me to sort of make a little petition for people to be judicious about when they give antibiotics. A boy who's got fevers, yes, he's hypotensive with a raised CRP, but all of his cultures previously were negative. So be judicious about who gets antibiotics and know what you're treating before you do give them. The other thing that I thought was interesting, and this was after I went home and sort of did a bit of research about what could be happening, he had this rash that was on his both of his ankles, and I thought that was somewhat of a clue, and I definitely would not have sort of noticed it or thought much of it unless I'd done a bit of research. So we'll talk about this a little bit later, but he had this this quite characteristic rash. What I sort of went home and did some reading on, when you sort of start to research some of the, I guess, the causes for cyclical or periodic fevers, the list is a mile long. There's quite a few differentials, and it's really sort of a little bit of, I'm not going to say clinical acumen because I don't have that, but you do get guided by how much you sort of get from the patient. Sometimes patients will give you a bit of a vibe and it sends you down one track more than another. This family was a migrant family, and it made me sort of go more down the path of something that might have been familial, and something that was, I didn't think that it was malignant, We'd sent off thyroid function, I sent off rheumatoid factor, and I sent off, there was a few other sort of viral panels that I sent off, and all of those came back negative. So I knew that we were sort of going into the weird and wonderful here. One of the things that sort of, I guess, struck my interest a little bit when I was doing my research was this set of diseases called familial periodic fever syndromes. There are 6 of them that are sort of most published about. And the 6 are things like familial Mediterranean fever, tumor necrosis factor receptor associated syndromes, and the HIDS, which is the hyperimmunoglobulinemia D syndrome. And then there are some others as well that I can't say I looked into a whole lot. When you look at the mode of inheritance, so this boy had well parents. Both of them didn't have similar episodes, and his brother was also well. So the way that I sort of deducted which ones I'm going to test for, I thought this is probably recessive. If it's going to be a genetic thing, it's probably not going to be the autosomal dominant kind. And that's why I decided to do the gene testing for the FMF, or the Familial Mediterranean, and the HIDS. By sheer dumb luck, he came positive for the MEFE, or the Familial Mediterranean fever gene. The diagnostic criteria for it, he seemed to fit quite a few of these. He didn't have any of the amyloid factors positive, so that I guess that this is one of the second types, but he did have the recurrent episodes of the peritonitis, and I guess the synovitis wasn't sort of completely characteristic, but he did say that he had random times where his knees would hurt. So, you know, whether I'm sort of drawing straws, it's hard to say, but definitely the recurrent febrile episodes, and the rash that I showed you earlier is quite characteristic for the erysipelas erythema. If you look them up on DermNet, it looks almost exactly like the picture that we'd taken. Is there a question in the chat there?
It's just me commending how you must feel like an absolute genius diagnosing this bizarre, wonderful condition.
Completely bizarre and completely dumb luck. There was no intelligence in this at all. So I'm going to throw out a question. Please try not to look it up, because I don't want any cheating. This is going to make it a bit easier to remember later on if this comes up in an exam. Can anyone sort of take a guess as to what is a known complication of familial Mediterranean fever? I probably gave it away a little bit. The options are, is it cardiac vessel aneurysms? Is it amyloidosis? Is it blindness, meningism, or psychosis? Jane, do you want to give it a stab?
I was going to ask Marian, in what you've told us so far, has he displayed any signs of a complication?
No.
Okay.
I have zero idea what amyloidosis is, but B.
You are spot on. It is amyloidosis. It's a known complication, especially for the untreated FMF, which draws me to the next question. What is the treatment for FMF? Do not look it up.
I'm going to guess Pred.
Prednisone?
I'm disappointed there's no antibiotics on this list. I thought IV augmented every 6 months sounded like a good treatment plan.
I'm pretty sure you gave this away, Marian. Wasn't it responded well to colchicine? It was on your slide.
Oh, it was. Oh gosh, I gave it away. It's definitely colchicine. So yeah, colchicine, it's like 500 micrograms twice a day, and you monitor them for sequelae, or I guess the complications of having colchicine. There is some sort of a biological that you can give them instead. I can't remember what it is, but there's another one that you can give if colchicine is starting to cause problems. yeah, that was basically the case. And I guess one of my, the two take-home messages that I wanted people to take from today. One is antimicrobial stewardship is very important. It will only take a couple of patients in ICU for you to realize how important it is and how much of a responsibility we have to be judicious about who gets antibiotics. And the other take-home message is going rural doesn't mean that you see less. In fact, I'd probably say that you see more of a variety. So yes, it's true that we see more of the bread and butter medicine where you're going to sort of make the most impact sometimes, because the common things are common and you're going to see a lot of that when you go rural. But we also see the rare stuff. That rare stuff doesn't just happen in big cities. And when you are working in a rural centre, often you are very involved on the team. You're not sort of standing in the corner of theatre, sort of cowering and trying not to get in the way. We want you to get involved, and you're absolutely going to be part of the team. So they're the things that I sort of wanted you to take from today. I want to say this link still works because I got somebody to try it the other day, but the Destination Rural hashtag that we started came from some research that was done by our Victorian doctors in training. We did a survey to see how much rural exposure people were getting in their JMO years, and the Destination Rural movement came of that, because we realised that people didn't get as much exposure once they hit internship and residency. And it's important to know that if you do go rural, you're not just going to be doing general practice, that you could be doing any other specialty. There's room for everyone. That's it.
Can I ask you a question, Marian?
No questions.
Yeah, no, it's an easy question.
Yeah.
I'm curious to know how you navigated the child's parents around the decision not to give antibiotics. There's obviously an expectation that they come in, they're unwell, they get antibiotics, he gets better, he goes home. Were there any particular difficulties in navigating that part of the consultation?
That's a really good question, Ben, because yes, I definitely got a little bit of almost disappointment from Mum when I said antibiotics are not what we're going to be using this time. And the way that I explained it was I said, we really need to know what we're treating before we treat it. So we're going to go looking at some of the rarer things that might be causing these symptoms, because I don't want to just throw antibiotics at your son and hope that things are going to get better. I actually want to know what's going on. And she was quite receptive to that, which is lucky, but it's something that can be quite challenging, especially when you're dealing with very worried parents, as they often are.
And what sort of time delay did you have to get that gene test back and a bit of an answer for the parents?
Yeah, so it was after we had discharged him, but I promised them, we're going to follow you up. I want you to make an appointment with me in 3 days. He's probably going to be well by then, because we've got documented evidence that this is a recurrent thing that seems to get better on its own. So I'm going to follow you up. You've got the emergency department open 24/7. Come in if it happens again, but we'll get the results back and then we can go from there.
I might point out, Marian, that takes a certain amount of clinical courage, and I think that's something we do quite well in rural, is that we back ourselves. We know we're resource limited, but we've got the process of seeing patients across the multiple spans of the healthcare system, whether it be community, inpatient, general practice. And we do need a certain amount of clinical courage to just go, yep, this is the plan, this is what we're going to do. I can only imagine how differently this child would have been treated in a tertiary hospital, and how many specialist teams would have been consulted, and the length of stay and the worry and the distress about being so far away from home, especially as a migrant family and English as a second language. It would be a very different type of experience for them compared to the one that they've had with you.
Yeah, you're very right, Ben. I think if anything, they might have had more delays in their diagnosis if they didn't have that continuity. Even it's very easy for somebody to be seeing this boy in emergency, in a very busy emergency department where you don't know much of the history, you haven't got much of the background on file there with you, and the easy answer would be, yes, I'm going to give you antibiotics because they worked last time, so here you go. It's very true. Dan, have you got your hand up?
I do. I was going to continue on what Ben's saying. I think you've saved the taxpayer near on $1 million, I dare say, by not getting this person to a quaternary centre, probably like Royal Children's somewhere, because I think this child, being a migrant as well, would have been locked away in a negative pressure isolation room. Probably would have made the news in some way because it would have leaked. Probably got a diagnostic laparoscopy at some point for some unknown reason. So I think you've actually done a fantastic job to manage this with your very broad, full scope of skills as a RG registrar. And what a good learning opportunity for you for some genetics as well.
Yes, definitely agree, Dan. And yeah, it's amazing how much more autonomy we sometimes get. There's a lot of power in the continuity that we have as rural generalists, and the autonomy is refreshing. I don't have to convince someone that I'm going to admit somebody to become an inpatient so I can investigate further. So it's great having that autonomy to be able to do things. Has anyone got any questions or anything else that you wanted to raise? I might ask you guys a quick question. So we've got a few new faces online. Could you do a little raise hand in the reactions at the bottom if you are a medical student? Brilliant. Can you raise your hand if you are a junior doctor, intern or resident? Brilliant. And one more, could you put up your hand if you are fairly certain you don't want to do general practice? This is all very positive. Very good. Well, our next meeting for the doctors in training is going to be next Thursday, because Peter will be otherwise occupied tomorrow night, so we're pushing it to next week. Santoshi, have you got a question?
Sorry, I joined in a little late.
Okay, welcome.
Thank you for that. It was, whatever I heard, it was like a real nice presentation. Thank you for that.
No, welcome. Thank you for joining us.
Marian, before we go, I just wanted to mention Ellie Clemenson, who's online, and I think one of the medical students that's attending, has won our Lucky Door Prize. So each thing we'll do a Lucky Door Prize. And it is an AirTag, so if you don't have an iPhone, let me know and we'll sort something else out. Sorry, Dan.
I just bought a pack of AirTags.
Well, you'll have to attend a lot of them and then you can
That's such a cool prize.
So we've got AirTags. So we'll have sort of giveaways, but there'll be some other giveaways as well. We do a monthly draw. At the moment, it's a infant Littmann stethoscope, but there are some other things available as we go through. I will send out an evaluation, and Marian did put up the QR code if you want to register for more information on rural medical careers and training and just general information on the various things. And we'll include the link as well when we send the evaluation out, or you can register now, and a couple of you have already done that. So thank you very much for that. What is an air tag, Jean? An air tag is something you will put in your bag, and if you lose your bag, you can track it on your phone. And there was a big story not long ago about how a man lost his luggage coming back from Singapore, and he was able to track it down in the back office of, I think, Sydney Airport. So, yeah, it's cool. Nanovirus. So thank you, everyone, for joining us on our first of our grand rounds. We hope to see you again in a couple of weeks, and but keep an eye out for topic and presenter information, and yeah, we'll go from there. But thank you, everyone, for joining us, and yeah, thank you to Marian for such an interesting case to kick off the grand rounds. So really appreciate it.
Thanks, Marian.
And we'll say goodnight. Thank you.
Thanks, Marian. Thanks, Peter.